Well, welcome everyone. Welcome and thank you so much for joining us today. I hope that the second hour is as invigorating as your first hour was. And as Dr. Drummond has mentioned, this is going to be about operating room sustainability. And the reason that I titled it this is because anesthesia is kind of the hot spot for climate change. And so we're going to discuss that. And you guys let me know if you have questions. So what's the problem? Well, operating rooms run 24/7. And because of that, we generate a lot of waste. But it's not like we can stop doing surgeries, even though COVID put some elective surgeries on hold. We're now trying to make up for that. And the production pressure to get people scheduled for surgery is increasing that as well. Operating rooms are the second largest source of waste in the United States. 4 billion tons of waste each year. And because of this waste, and I heard some of you talking about that in the previous lecture, the gowns alone, just the production of them produce greenhouse gases, solid, and water waste as well, because we have a lot of single-use supplies. Are there situations where we need single-use supplies? Yes, absolutely so. But reusable gowns are hopefully going to start being more of an option. And listening to you discussing that, I started kind of thinking, well, where may we be able to use that? And I think that one of you brought up a really good topic in that in surgery, oftentimes you'll go in, you'll put on your gown, your gloves, and like the scrub techs especially will set up the tables to make sure that everything is going to work and that you have all the supplies that you need in those kits. Well, if you have a reusable gown and it's sterile, why couldn't you keep it sterile somehow in that operating room and reuse it for that next setup and maybe put the disposable on afterwards? So we use a lot of water in the operating room. I think you've seen orthopedic surgeons come walking out of their rooms and they've got on those hip waiter boots, right? So yeah, we're using a lot of water. We've got a lot of plastics. We have medications, and those medications and how they're packaged and how we give them can contribute to waste. And then of course we've got the gases, and I'm going to show you how that's important in the operating room. So our anesthetic medications, our anesthetic gases, are greenhouse gases. They contribute to climate change. They trap heat in the atmosphere, and they're known as waste anesthetic gases. And we're going to cover this a little bit more so that you kind of understand it. They can pose harm to not only the environment, but to you as someone in that occupation. And we're going to talk about how that's a concern as well. So just some basic stuff here so that we can kind of break it down from where I started. So our greenhouse gases, they're called greenhouse gases because they leave a carbon footprint. Carbon dioxide makes up 80% of this, and that comes from most of it burning fossil fuels, gas in our cars, those sorts of things. Then we have nitrous oxide. That's about 6.2%, and that goes into the wastewater. And we in anesthesia use nitrous oxide. So we're going to talk about that some more too. And then we have our fluorinated gases. And I put this in here specifically because they are ozone depleting. And we're going to talk about that a little bit more as well. We're just setting the foundation for everything we're going to talk about. All right. So what is global warming potential? Well, that's a measure of how much energy the emissions of 1 ton of gas will absorb over time. And that's typically 100 years. And this understanding is going to help you see how our anesthetic gases and carbon dioxide, because that's part of our problem too, and part of the reason that we're a hotspot. So then we need to talk more about the global warming potential. Well, so nitrous oxide has a GWP of 265. Our fluorinated gases, and Notice the significant number here. It's 740 to 50,000. We have hydrofluorocarbons, perfluorocarbons, sulfur hexafluoride, nitrogen trifluoride. These are all synthetic, powerful greenhouse gases. Smaller quantities, yet very potent, ozone depleting, and trap heat more so than CO2. So now we're going to go back to carbon dioxide for just a minute so that we can kind of build a better picture here. So what is our role? Where carbon dioxide has 6,340 metric tons per year, and it is the one that all of the other gases are measured against. It has a GWP of 1. Transportation gives you 28% of this greenhouse gas emissions, electricity, 24%, and that comes from the fossil fuels used to create it, and then industry is 12%. So, as I mentioned earlier, carbon dioxide is the greenhouse gas for which all others are measured. The thing that carbon dioxide has that all the other gases doesn't is that it has a carbon sink. The plants, using photosynthesis, absorb that carbon dioxide, and that helps them because they absorb that CO2. I used to live in Maine, and we have so much green forest in Maine that all of that wood is still now being used to build homes. It's being manufactured to do those things. It was also used to build the big masted ships when we were first starting out as a country. So we've got a pretty large sink in all of those trees and forests in Maine. We don't have so much of that here, especially in southern Arizona. So how does carbon dioxide play into anesthesia? Well, a lot of that is based on our anesthesia machines and the circuits. And as you can see here, there's directional valves. So the medication that we give goes to the patient. There's a Y piece here. That's how it's connected. And I'm sure many of you have seen them in the intensive care units hooked to the endotracheal tubes and those sorts of things. We also have the exhalation. Oh, sorry, this is the inspiration. This is the exhalation. This here is a carbon dioxide absorber. And if it's not checked for leaks, checked for particle size, and we've just now gotten to the point where this absorption process, these particles are now not as toxic as they used to be. When we would change these out, when I was first starting, we would have to put on an N95, gown, gloves, all those sorts of things to dispose of these. And now we don't as much because we're getting better with the process. And I would think that in the next few years, we're going to have one that will not be toxic at all. We've also got a scavenger system that we're going to talk about a little bit later as well and explain this to you. But our carbon dioxide is also, or the carbon dioxide is also a problem. So what I wanted to show you with this picture is the concentration in parts per million. And I want you to see how we are steadily climbing. And that is why this is such a problem. So why is this important to our sustainability? Well, what I want you to notice with this picture is that as we are having a patient breathe in oxygen, they are exhaling carbon dioxide. This isn't a closed system here. And you're going to notice that here, there's only one set of tubing. Well, our manufacturers are getting a little bit better. It used to be that there was an inspiratory and an expiratory side. Now the expiratory side is on the inside of that one piece of tubing. So we've gotten rid of one huge piece of plastic, but it's still not good. And they're exhaling. When we are doing a pediatric induction, those children often will turn their head. We're not getting as good of a seal as we could be. We're using nitrous oxide on those inductions, and that all leaks out into the environment. So if you're going to be in that operating room, step back from when they're giving those induction drugs and the anesthetic agents. So we're going to kind of come back to this. The World Health Organization states that there are over 3 million surgeries worldwide every year. That's a lot of surgery, right? So what's the global impact? Well, approximately 200 million of the 300 million procedures being done each year involve anesthetic gases. So let's talk a little bit about the anesthetic gases. There are several different ways here, and we're going to talk about each one and how they impact or influence our climate health. So anesthesia delivery, we can give it through intravenous medications. We can give it through regional anesthetics. Those are peripheral nerve blocks, spinals, and epidurals, and then our inhalational gases. And I don't know who made this picture, but it is completely inaccurate. This one is desflurane. It's a specialized vaporizer. It has to be heated, and that makes it, and you're going to see as we talk about these. This sevoflurane, it's mislabeled. This should be isoflurane, and then this one should be sevoflurane. All right, so our anesthetic methods. We're going to talk first of all about intravenous. We use them for induction. That's how we get patients off to sleep often. We do total IV anesthesia, and that's referred to as a TIVA. And then we also do beer blocks through intravenous medications. So what's the impact of those medications? Well, as you can see over here in this graphic, many of our medications come pre-mixed in plastic syringes that end up being wasted. The way we talked about GWPs for gases, this is how we do it for our medications. We look at persistence, bioaccumulation, and toxicity. So they get a PBT score. This score is the total for each one of those categories. So they get a score of 0 to 3 for persistence, 0 to 3 for toxicity, and 0 to 3 for bioaccumulation. And a score of 9 is the worst, unlike gymnastics, where that would be a fantastic score. So now we're going to look at our anesthetic methods and keep going with the IV stuff. So I just picked a couple of the medications that we use for pretty much every single anesthetic case done. First one is antibiotic, Ansef. We give Ansef, and it's usually 2 grams based on patient weight, according to CMS, for every case to ward off any sort of complications of wound healing and those sorts of things. It does not undergo significant metabolism in the body. It's excreted by the kidneys unchanged into the wastewater system. Current wastewater systems do not extract cefazolin. And you kind of question this number of antibiotic bacteria, and it's leading to the question of, is this wastage causing antibiotic resistant bacteria in wastewater plants? And I can tell you that my son, who is a chemical engineer, and this is his forte in cleaning our water, yeah, he thinks it definitely contributes to this. Propofol. Well, this is a drug that we probably give 10 to 20 times a day. You see it running on the IV poles in the intensive care units. We use it everywhere. It's one of the most wasted medications in anesthesia. We waste a third to half of it. And the reason for this is because we draw up, it comes in a 20 ml, a 50 ml, and a 100 ml vial. We don't just draw up 2 20s, give 20, see what happens. We typically say, okay, so I'm going to run a TIVA, I'm going to need this amount. And so then we end up wasting what we haven't used. It's significant for bioaccumulation based on its lipid solubility. It's one of the things that makes it a great anesthetic medication, but because of that, it has bioaccumulation. It stays longer. Less than 1% is excreted unchanged, and 60% of that is based on hepatic glucuronidation. It does not degrade. It's toxic to aquatic species. Current wastewater treatment, and this is something that my son is working on, is the anaerobic digesters, and those are minimally effective. They're very effective on many, many other things, but they are not effective for this. And to fully remove it, it has to be incinerated at 1,000 degrees Celsius for over 2 seconds. So that's not going to happen. So now we're going to move on to the regional. Regional spinals, epidurals, peripheral nerve blocks, as I mentioned earlier. And as you can see in this picture, they're using ultrasound to guide their regional peripheral nerve blocks. A couple of medications that we typically use in these, we use lidocaine. It's pretty insignificant for environmental risk, but we can't use it for spinals epidurals because it is toxic to that system. It has a low potential for bioaccumulation. Its PBT is 3. If you notice bupivacaine is one of those medications that we use for everything. It's like propofol when it comes to regional anesthesia. It's harmful to aquatic organism. They have long-term effects from that. It's got a PBT score of 5. It's not readily biodegradable. It can be disposed in water, but the incineration, as we mentioned in propofol, at that high heat, that is what is recommended. And I don't know if you guys are seeing this. I don't know how many of you are in the operating rooms, but typically now we've got, rather than just one waste bin, we sometimes have 3. And the problem with that is that the education and training behind that has not been enough that people are doing it correctly. And so the glass vials end up in the wrong place, the medications end up in the wrong place, and all of the plastic, the syringes and everything that we have. So another concern with regional is that very rarely are we doing that as a solo anesthetic. If you're placing a peripheral nerve block, that is for pain management after the procedure. If you've had a spinal, typically you don't need any other kind of anesthesia. The only place where we're not typically giving a multitude of other things is for a C-section. And we do it that way so that we're not harming the mom and the baby. But most people say they're having a total knee or something like that. Those patients will get some sedation. So they'll get some IV sedation as well with the propofol so that they're nice and relaxed. So then again, we're still using those medications. We're still using the plastic syringes and the tubing, the IV tubing. And as you can see, this is an epidural tray. And so you've got the gowns and gloves to place this sterilely. You may need an airway device like an oxygen mask or a nasal cannula. And then sometimes you'll need the anesthetic gases on top of. So this is something that I found very interesting when I moved to Arizona. I would review the case logs for our people in training, and I would see that sometimes they would list that their patient got a nerve block, they got a spinal, and then they got sedation on top of that. And sometimes the sedation, the surgeon would request a general anesthetic. So essentially, they were getting 3 types of anesthesia for one case that could easily be done with a spinal. It's like throwing a grenade at an anthill. But when you ask them about it, they say, well, that's what the surgeon wants, so that's what we give the surgeon. Think of the waste. All right, so we call those combined techniques. The combined technique has the greatest carbon footprint in comparison to a general anesthetic only or a spinal anesthetic only. And I can tell you that I have started changing my practice based on this information alone. I firmly believe that a spinal or an epidural are the best practice as far as making sure that the patient is comfortable. But if I'm questioning whether that is the best plan or a general is the best plan, I go strictly with the general so that I'm not contributing to this. A general anesthesia alone has a 14.9% carbon footprint, a spinal only 16.9, and some of that is based on the plastic tray, the gown, the gloves, everything that goes into placing the spinal. And notice that the combined is 18.5%. 90% of those regional anesthetics that we do are a combined anesthetic. And so we're contributing more. So now we're going to go to inhalational, and those are the use of the volatile agents. We use them for induction, and we use them for maintenance of general anesthesia. It's estimated healthcare facilities produce 10 to 15% of greenhouse gases in the United States. In 2023, Massachusetts General reported anesthesia accounts for 43% of its greenhouse gas emissions. That's a pretty significant amount. And I'll be the first to admit that Massachusetts General is a beast of a facility, but that's still a lot of greenhouse gases that they are emitting. So let's look at each one of our anesthetic agents so that you can understand them and what they contribute to the greenhouse gases. So the first one, and I chose to start with sevoflurane because it is the anesthetic gas that we use the most. And the reason for it is that it doesn't have a pungent smell as you turn it on. So we're using it for pediatric inductions. It's highly fluorinated methyl isopropyl ether. Notice I said ether. It's an organofluorine compound. It's a halogenated hydrocarbon, and it is a greenhouse gas. But you can see, and this is how we all memorize it when we're in school, you count the number of fluorines, and that tells you which gas you're going to be using. Then we have desflurane. Now, this is the one that I said needs a special vaporizer. It must be heated. Otherwise, it's very volatile. It's also a highly fluorinated methyl ethyl ether. It is a racemic mixture of two optical isomers that makes it an enantiomer. It is a halogenated hydrocarbon. It is a greenhouse gas and ozone depleter. Now notice it's got one less fluorine than your sevoflurane, and it also has a hydrogen here. That is one of the things that makes it unstable. Then we have isoflurane. Isoflurane is one of those older anesthetic gases that very few people are actually using anymore unless you have a specific case for it. It's very inexpensive. The problem with it, and the reason that people are getting away from using it, is that it is slow on the uptake and it is slow to come off. And with the production pressure that we're seeing in the operating rooms now, nobody has time to wait for that to turn off. It's an isomer of enflurane. We no longer use enflurane because it was so volatile that it could start a fire. So we're not so much using that. It's also a racemic mixture that makes it chiral. It's an organofluorine compound, halogenated hydrocarbon greenhouse gas. And if you notice, it's a little bit different. Basically, all these chemists are doing is, okay, if I add a fluorine here, what makes it stable? If I take a fluorine here, what makes it unstable? If you replace this chlorine with a fluorine, then you would have desflurane. And that's how they created desflurane, by substituting a fluorine for the chlorine. All right, now we're going to get into nitrous oxide, because I mentioned that earlier as being one of our problems and the reason that anesthesia is the hotspot. We use it for induction or maintenance of general anesthesia. It's a wonderful drug. It's odorless, it's colorless. It's often used as a carrier gas. A carrier gas is one of those where if you want somebody to go off to sleep quickly, let's say our pediatric patients, if you use that as your carrier gas, they go off to sleep much, much faster. It is a greenhouse gas and it is an ozone depleter. So, not a good thing in our realm of climate health. So we're going to come back here quickly and look at the global warming potential of our gases, our anesthetic gases. Carbon dioxide is a 1. Sevoflurane is 130. Luckily, that's the one, the volatile agent that we use the most. Then there's isoflurane, which is 510, desflurane. This is the one that is really the problem, 2,540. Then we've got nitrous oxide, which is 310. Now, do I think I'm ever going to get rid of nitrous oxide altogether? Nope, absolutely not. Have I limited it in my practice? Yes. I used to occasionally turn it on when I needed just a little bit of an agent to keep a patient comfortable towards the end of a procedure, when the surgeon was closing or they were having someone else close for them, so that I could start to turn down my other volatile agent. I don't really do that anymore. So I have changed my practice based on some of this. So now I just kind of want to talk about, we talked about the global warming potential, but now I want to look at it as comparison to the lifetime. This is the number of years that it stays in our environment. Nitrous oxide, 114 years. Carbon dioxide, 5 to 200 years. Luckily, we've got that sink from our plants for them. Desflurane, 8.9 to 21. Why are these smaller in comparison? Well, they're smaller because we don't use as much of them. We use a percentage of them, and we're getting smart now in that we're using scavenging systems to trap some of it, and we are also using lower flows, and we're going to talk about that. So I want to come back to nitrous oxide because I want to talk about the fact that it's not just our operating rooms that are using it. It's being used in dentistry. It's being used in mental health facilities. It's being used in respiratory care. And then I got to mention ourselves. In Europe, nitrous oxide is on one of these machines. We haven't really adopted that here in the United States as much, but pregnant women who are in labor and they're not getting comfortable, they can breathe a little bit of nitrous oxide, get comfortable, and come back. It's the most important greenhouse gas after methane and carbon, and you saw the number of years that it stays in the environment. It's the biggest human-related threat to the ozone layer because we're using it in so many different locations. It stays in the atmosphere for the amount of time that I told you, and 40% of total nitrous emissions comes from things that we as providers are doing. So desflurane. And this is the agent that has that very specialized vaporizer. A 240 milliliter bottle of desflurane, completely vaporized, is equal to 886 kilos of carbon dioxide. It's equivalent of driving 3,072 miles, approximately like driving from Seattle, Washington to Portland, Maine. It's 300 times the global warming potential of carbon. So I just kind of want to show you why desflurane is one of those agents. And I'll be honest with you, I loved desflurane when it first came out. And there are certain cases that I still love using it for, but I don't use it as often as I used to. I have changed my practice based on this. But I kind of liked how the map kind of shows you which ones are our biggest ones and which ones are, okay, we might have to use those. Nitrous and desflurane, those are the two that we don't want to use. All right, so then we've got just a picture of what a normal anesthetic workstation may look like. So now we're going to talk about the scavenging systems, and these are very important for you as a provider who may be in the operating room and your occupational exposure. We use a closed circuit, and whether that's just one piece of tubing or two, it's still a closed circuit. Gases or vapors only leave the circuit through the scavenging system. It's a necessary part of the anesthesia machine, and it is where we collect the waste anesthetic gases and keep them from spreading out into the operating room. The concern with that is that if somebody hasn't checked the scavenging system, and I'll tell you now that it doesn't always happen. When I was in training, I would be the first person into the room and I would check everything out. And I had to constantly change my scavenging system because it hadn't been dialed down. And you wonder how much of that anesthetic gas is getting out into that open system. It is removed from the OR. Here's the other problem. It's vented into the atmosphere, contributing to greenhouse gases. It's vented outside of the operating room and outside of the ORs and then outside of the facility. Yes, it's only a small amount, but yes, it does contribute. So now something that we're looking at are changing our fresh gas flows. Our anesthesia machines have become so technologic that it now tells you, and you can see right over here, it says, what is your total fresh gas? It's too much. You're using too much here. So you can dial it down. Part of the concern with that is that you have reduced inhaled anesthetics, decreased cost, decreased waste, fewer greenhouse gas effects. Not everybody is following the rules for the fresh gas flows. Many people say, okay, well, I'm going to induce with this much oxygen and then I'm going to turn it down. It can be lung protective as well if you are following these rules. One of the concerns, and this is with sevoflurane, and it's based on an FDA label, which is outdated, but to get anything approved by the FDA is, well, you know, it takes years. They mislabeled it. They said that it was based on compound A, causing toxicity to the liver if you used fresh gas flows. So then they come back and say, well, you now have to use 1 liter per minute for up to 2 hours and not less than 2 liters per minute for longer procedures. Well, that's how they labeled it when it started. The thing that's changed is that our absorbents have changed. And based on that, you can now use lower flows much longer. And you can use a low flow technique, which is 0.5 to 1 liter per minute, a minimal flow technique, which is 0.25 to 0.5 liters per minute. And then there's the metabolic flow. I don't really use the metabolic flow. I'm not that comfortable with it yet, but I do use lower fresh gas flows. And I use the machine to tell me I'm at too much or I'm not at enough. And this is the formula to calculate out what your fresh gas flow would be. If you want to sit and do that calculation, by all means, go for it. I just trust my machine. I know that that calculation has been put into the machine. I do make my residents do it though. So our absorbents. Well, the absorbents, I showed you the picture earlier, and this is what it looks like in the operating room itself. All these different particles. They absorb the carbon dioxide. They may produce carbon monoxide, and we're going to talk about that. You use end-tidal CO2 monitoring to indicate, and you can see it here. We've got all of these beautiful graphic waves now that show us that our inspired CO2, and that can be caused because you've got an absorbent that is exhausted. It's been used up. It should have been thrown away. The problem is that it changes color. It should turn purple. But let's say it's Friday evening, you finish your case, you leave for the weekend, you come back, that absorbent isn't purple anymore. It's white again. And so you don't know that it's exhausted until you turn on your anesthesia machine and you start seeing that they're rebreathing CO2. So if you look at the chemical composition of those absorbents, it has really changed. Now we're using calcium hydroxide based products, much more so than what we were using prior to. And these newer products, they're in development now, and they're not going to rely on the chemical reaction from exhaled carbon dioxide mixing with that absorbent. It's now just going to eliminate the carbon dioxide without those particles. And those particles, if they get too tight or they're moist or those sorts of things, that's when you can start to get the carbon monoxide. And that's the last thing that you want for your patients. So anesthetic gases that I mentioned earlier, they undergo minimal metabolism in the body, and greater than 95% is eliminated, notice this, unchanged during exhalation. In the United States alone, it's been documented that over 250,000 healthcare workers are potentially exposed to waste anesthetic gases. And part of that comes from the induction. If you have a patient who needs anesthetic gases rather than IV medications to get off to sleep, no matter what, you can't get a 100% seal of the mask on that patient's face. And so it's leaking the anesthetic gases. And this places healthcare workers at risk for potential problems. It affects you in the operating rooms, in the PACU. Those patients are still, no matter how long you've had that anesthetic gas off, they're still exhaling some anesthetic gases. So you're going to see it in the recovery room as well. And I just looked at a proposed study where they wanted to have anesthesia machines in the intensive care units rather than IV sedation. I don't know that you really need that exposure in the ICUs, but you know, I don't think it's much more comfortable than a propofol drip or some sort of other sedation to keep someone intubated. It can lead to liver and kidney damage because you saw the biotransformation. Elevated plasma markers, we're seeing those in healthcare workers, and it's causing inflammation for them. People working in the operating rooms have a higher concern with miscarriage, preterm birth, and congenital abnormalities. It can be neurotoxic. And because of this, NIOSH has set up exposure standards. It's 25 parts per million for nitrous oxide, 2 parts per million for halogenated agents. So you can see they have a very small window here for the halogenated agents. A really interesting story is I used to be the rural facilities director for a large group of hospitals, and we would go in and provide anesthetic services for smaller critical access hospitals. And I learned after the first couple of those that I helped set up to ask about their standard operating procedures, their policy and procedure manuals, because when they asked me to help them update it, what I found in one of the policies was it hadn't been updated. I can't even tell you how many years, probably at least 25, because the policy and procedure stated that as an anesthesia provider, you were to turn the gas on, hold the mask to your face, and sniff to make sure that the gas was running. Yeah, OSHA would love that one, right? Yeah, it's a big no. So not only do you just need to trust your anesthesia machine, but there's an app for that. There's an app for everything. There are apps that you can download on your phone that tell you, according to this patient weight and height, this is the amount of fresh gas flow you need for these different agents. And this is the actual picture from the different apps and what it will calculate for you. And I think there's an app for just about everything. So I highly encourage you using this. So waste products in the operating room. We can't just blame anesthesia for everything, even though we do get blamed for everything. We have single-use supplies. We have those syringes. We waste a ton of water. This is a supply room. Notice everything is wrapped in plastic. We have drapes. We have all kinds of medications. And this is just one cart. If you've ever been in an operating room, there's usually a core that has multiple carts for every single possible room. And so think of the waste. They can contribute 70% of hospital waste. A single case can produce more waste than a family of 4 over a week. One case alone. Now, I'm going to come back to anesthesia because 25% of this, well, yeah, it's ours. It's all those syringes, it's the gases, it's those sorts of things. Here's the thing that I find really interesting, and I challenge all of you to help. 40% of this waste is potentially recyclable. So start that recycle program for your hospitals. Single-use items, well, these are our gowns, our gloves, caps, booties, kits, such as the IV kits, the spinal kits. I put some disposables over here so that you could kind of see what it looks like. Our endotracheal tubes. Now, can we reuse an endotracheal tube? Nope, absolutely not, because it's invasive. We're going to talk about LMAs, suction canisters, those sorts of things. I find it very interesting, but the suction canisters are automatically changed between cases, whether we've used them or we haven't. So the surgical gowns and drapes, you guys were having this discussion a little bit earlier. They account for 30% of our surgical textile use. You gown and glove when you go up to there. It is our first line protection for providers and the patient from the providers. So what they found is that the economics vary. Some of it depends on the size of your facility. If your facility has purchasing power, you're going to get a lot more for less. But it's also dependent on personal preference. I can't even tell you how many surveys I've been a part of where they ask the provider, what are you interested in getting? What do you prefer? And I am never, and I can say never, on the side that gets the preference for what we like. And it usually comes down to the cost. Consider the life cycle of a reusable gown. You're adding time to that, which is good, but you're also looking at water usage and transportation. And the reason that I include transportation is because there are very few facilities anymore who do their own laundry. It's loaded into a truck and it's sent someplace else. But reusable increases sustainability, decreased energy uses, and it decreases our carbon footprint. We can't use it for everything or every case. If you've got a trauma and a lot of blood and those sorts of things, you're not going to likely be able to reuse a gown, but you can use it for other things. Just consider what you can use it for. This is something that I think that we as anesthesia can change. Our laryngeal mask airways, we shifted from reusable to disposable. It's easier. Didn't take somebody to clean it. It didn't do all these sorts of things. So we looked at, there's been a couple of different studies now. And what they found is that if you look at the life cycle assessment, then you have a life cycle of a reusable is 40 disposable LMAs. But you're going to have people coming back to you going, well, no, it's the cost. Well, a disposable is single LMA 9+, depending on your purchasing power. It's made of polyvinyl chloride, and that contributes to greenhouse gases. That's your disposables. It's 11.3 kilos of, and the E is for emission of greenhouse gas, of your carbon dioxide. A human impact, cancer. It's been known to cause cancer. A reusable, if you look, it's $8, and that's taking into account everything. That's the cleaning and everything else, and it releases 7.4 kilos of carbon dioxide. It's 50% less negative on the environmental impact. Now, some of that takes into account, you must take into account what it's being cleaned with, because obviously it's invasive, so it must be cleaned between patients. So this is something that I found very interesting being a pediatric practitioner is Project Spruce. It's a pediatric focus because like I mentioned with pediatrics, you're holding the mask up to their face. They're not going to let you start an IV to get them off to sleep. So they're breathing in those anesthetic gases that get them off to sleep. And notice this was 2023. They found an 87% reduction in their greenhouse gas emissions used in the operating room, and this was over a 5-year period. This is one of the reasons that I really liked and am using this study. What they did is they started off with educational initiatives, which is what you guys are doing now. You can't make a change if you don't know what the change may or should look like. Then they put on practice constraints. And what they did, and this is really no big deal because they took the desflurane vaporizers off. Well, we don't use desflurane for induction agents on pediatric patients because it smells awful. And so kids aren't going to let you hold that to their face. This corresponded with a 50% reduction of carbon dioxide emissions. I don't know how they made that happen in a pediatric population unless it was being used in adults as well, which it must have been, but they didn't state that in the article. So then they made protocol changes as well, and they decreased the anesthesia machine fresh gas flows. The default is typically set 1:1. They changed it and they saw a similarly robust emission reduction. So this is a simple thing that can be done. Do I think that it needs to be set as the default? No, absolutely not. Your providers should know and monitor it once they've been educated to just use low flows. The other piece of it is that they shared this data with providers real time. They didn't wait 5 years and then share the data. They shared it consistently in their weekly meetings. And so then they started seeing a change in their use of fresh gas flows being lower, higher use of propofol and TIVAs, and those sorts of things. So how can we in anesthesia or in the operating room decrease our greenhouse emissions? And I'm going to give you some ideas, and then I kind of want to hear from you since now you've heard this. Avoid nitrous oxide as your carrier gas. Your patients are going to go off to sleep just as quickly with just the volatile agent. And I can tell you that this look being given by the patient, I've had kids give me this look. What are you doing to me? Decrease your fresh gas flows, use the lowest flows that you can possibly use. Turn off your gases during intubations. I've seen this so frequently where they'll get the patient off to sleep. They'll need just a little bit more, so they'll turn on some anesthetic agent. They go to do the intubation and they leave the gas on. You're gassing everyone around you at that point. Reduce your oxygen flows when appropriate. If you're doing a sedation case and you've got a patient on an oxygen mask, use the lowest flow that you can possibly use. Most people will turn it up 10 to 15. They don't need that much oxygen. Use regional anesthesia as the solo anesthetic agent or a TIVA if you can possibly do it. Avoid combination techniques. Monitor and use non-reactive CO2 absorbents. Again, I think in the future, we're going to see those being much, much better. They're working on that now. Use carbon filters. These kind of get expensive for anesthetic gas neutralization. We use those carbon filters for patients who may have malignant hyperthermia now, but the cost of them is about $30 for each filter. So most facilities aren't going to let you use them. Monitor your scavenging systems for leaks. Reduce your single plastics as much as you possibly can. Here's the big one. If each and every one of us would just go in and start a recycling program in your facility, we can decrease the amount of solid waste. Remove your desflurane vaporizers. Now, Big Pharma's not going to like me for telling you that, and I used to be friends with the desflurane rep where I came from. It's a great drug, but you know, sometimes you've got to just do what's best for the climate and yourself, and then educate everybody. And then here's all of the references. But what I wanted to talk with you guys all about was, you know, what questions do you have for me, and what do you see as being the potential of how we can eliminate some of that waste?